All right, great, thank you. Welcome everyone. It's nice to have you back in the series. It was a pleasure for me to welcome all the way Dr. John Kaku. It's always a pleasure to allow him to be able to join us and for us to be able to spend time with him and supporters here. It's great. So Dr. Kaku obtained his orthodontic degree from Boston University and won the Joseph E. Johnson Table Clinic Award for non-extraction treatment in the Asian face at the 2013 AAO in Philadelphia. Dr. Kaku has published over 40 articles and lectures worldwide, 2 private practices in Japan. Dr. Kaku therapy simplified, fewer trays, less time, and better results. So please join me in welcoming all the way from Tokyo, Japan, Dr. John Kaku.
Thank you very much, Tyler. Well, before my start, and I just introduce the way of practice I work every day. Maybe the tour of our office, about 2 minutes. Okay, today I wanted to share some of the informations about the class 3 treatment. And my orthodontic philosophy and technique, as well as the way of thinking about orthodontics, is based on my postgraduate program I received back to 1993. Dr. Gennari and Norman Setlin and Ray Greenfield is really my mentor of orthodontics. I called this orthodontic philosophy is MOO orthodontics. This is written by one of the textbook, and I need to. Let me see. Sorry. I want to share the information for class 3 treatment for early mixed dentitions. Early mixed dentition today, we are not allowed to submit Invisalign because it's only 4 permanent incisors and all the primary teeth except the first permanent molars. So in this case, we need to do something before the aligners, how you prepare those phase 1 treatments. If we are thinking about phase 1, we are thinking about maybe some of the corrections for the skeletal class 3. And if you are taking ABO exam, what is a skeletal class 3? The skeletal class 3 is -2 degree A and B. If it's that's more than -2, which is a skeletal class 3. One of the skeletal class 3 is a maxillary deficiency, and one of the skeletal class 3 mandibular prognathism. Option for too big lower jaw is orthodontic surgery and the camouflage treatment. And maxillary deficiency is the options, of course, the surgery, but there are some options to advance the maxillary jaws. The most common mechanical advancements of maxillary jaw is to use a facial mask according to Anglo Orthodontics. And they have 79 children using the facial mask, and they spend it about 18 months to correct class 3 to class 1s. So those are the phase 1 treatments. The average children is 8 years old. So those all 8 years of children with a facial mask, on this article in the Anglo Orthodontics, you need about a year and a half. And there, before treatments, SNA is 80, SNB is 79, so ANB is 1.2, which is not that severe class 3. And end result is SNA 82, SNB 78, ANB 3.7, so which is not that severe in these articles. So your practice, you use a facial mask, and this lateral photo to me, this is not so difficult skeletal class 3, even though the title of article is a skeletal. So 1 degree A and B for this kind of cases, to me, is not face mask cases. To me today, I would use facial mask. So my case here, I want to correct class 3 to class 1, not the facial mask. But I look at frontal view, small narrow maxilla, there are some crossbites in the back, which require some of the expansions. Some of the doctors may criticize expansions. I want to mention about some of advantage and disadvantage. My case, 79 children from the Anglo Orthodontics 1 degree, but this is minus 0.2, so which is a little bit more difficult cases. And I use expansion appliance and the motions on the lower arch. Then we use expansion appliance during digitalizations of the permanent molars, and then 6 months later, the lateral is out, and put the braces on and correct underbite of those anteriors. After we correct lateral inside alignments, and then we finish those class 3 to class 1, which is relatively short to me. And those are separate metric numbers from minus 0.2 to 4 A and Bs, which is significant change. In this particular case, minus 0.2 to 4 A and B, compared to 79 children from Anglo Orthodontics, 1.2, 3.7, to me, cephalometrically almost the same. Facial mask require a year and a half, and a lot of cooperation with the big device, and patient has some discomforts, very difficult to use it. During sleeping, the facial mask comes out. So these kind of problems can compensate because this is everything in the mouth. Children can wear elastic all the time instead of only nighttime facial mask. So advantage of combined together, this we can minimize the total treatment time. This is a primary dentition on the posterior teeth. But now what happens for young teenagers? So this is they are talking about some of skeletal class 3, and this is 13 years old. And the how long the facial mask was used, but this is a photo from the articles. So they say the skeletal class 3, but A and B is 0. So to me, it's not that really true skeletal class 3. And this article shows that before treatment, A and B 0, and after treatment, A and B 0. So not much skeletal differences. So my cases are similar and class 3s. And the lower is so minus 0.2. And AJO minus 0.2 is very similar, and the ages are similar, almost the same age. So my patient here, and class 3 profile, and consideration of incisor showing. In these patients, when smile, we don't really see much of how smile. So we want to show inside. The slide on the left is more balanced smile arc. The photo on the right doesn't show much. It's a different arch, so it's not aesthetically pleasing. So we want to make, when the patient smile, showing more. We are actually loosening the incisor showing as you age. So after under 30 years old, 3.4 millimeter upper incisor, you can see it. But after over 60 years old, you don't show much. And this is one of the examples. After 60 years old, you don't show upper incisors. This is the Japanese Prime Minister and the son, and showing the son shows upper incisor when they smile. Well, the class 3 cases, if we use class 3 elastic, we exclude lower incisors, which compromise incisor showing. And this is a classic article with some class 3 open bite, use class 3 elastic, exclude incisors, so that article showing the good class 3 open bite corrected, nicely finished in the mouth. But if I look at the facial photos, I don't see upper incisors showing at the end of treatment. So that scan the mouth, and I created some of the setting inside. Well, we wanted to speed up the treatment. Now the handy Schein joined the accelerant, so that we use the vibration device for this case. So we have
Healthy, beautiful smiles, faster with Accelerant Optima. Accelerant Optima is a state-of-the-art accelerated orthodontic device with a comprehensive suite of technology-driven features. It is intended for use during orthodontic treatment in conjunction with braces or aligners to help facilitate tooth movement. Added to treatment, Accelerant Optima improves the orthodontic experience with faster tooth movement, reduced discomfort, and an easy-to-use patient engagement application. Accelerant uses soft pulse technology to safely accelerate tooth movement by as much as 50%. It does this by generating small vibrations called micropulses to gently accelerate the movement of your teeth as they are guided by your orthodontics. Treatment takes only 20 minutes a day, making it easy to fit in with your daily routine. Talk to your orthodontist about Accelerant today. For more information, visit accelerant.com.
So we use a device, a vibration device, and then use class 3 elastics. And the class 3 elastic, we don't use long class 3. It's kind of a triangle way of using it, and make the stagings, the lower incisor intrusions, and some of the extrusions can happen with the triangle elastic. So that this case, we change not every 2 weeks, we change every 5 days. So this is 4 months later, and I resubmit. We want to extrude more and intrusions more, and then make the incisor showing better. So the 4 months later, I got the new set, and then finished another stage, and we want to go more, and I make it intrusions and extrusions sequences. So the entire treatment completed about 11 months, and the before and after treatment. And you can see how lower incisors are maintained or slightly intruded, and upper incisors are extruded. So this can happen combinations with some of the vibration device which enhance the retentions of aligners. And you can see some of the aesthetic line improving before and after treatment. And you can see incisor showing was improved. I can see more of the upper incisors relative to lower lip lines. So that's my conclusion number 2. If you combine with aligners, and maybe we can eliminate facial mask. So now I want to explain about some of transverse corrections. We are focusing the sometimes do the transverse first.
Trust me, mine is better.
So those are skeletal expansion for adult patients. We use mini-screw assisted RPE that's installed at the roof of the mouth, and we can see orthopedic expansions. So this is the case that patients' posterior teeth, you can see some of the gum exposures. The enamel is out of the gums. And you can see the cross bites at the beginning of treatment. You're afraid to use regular expansion appliance because you will remove the roots out of the gums and out of the bones. So in this case, because of the gum recession, I decided to extract the lower incisors out. And then expand, but we use mini-screw assisted RPE to go at transverse expansions. So we place expansion appliance for 2 weeks, and then 1 month, and then I gain enough 2 months, and then I remove the arms. After the arms out, then we scan the patient's teeth and creating the aligners. We are holding the expansions during the aligners. We created the series of aligners. Because this patient has a third molar in the mouth, we decided to take second molars out and use the third molars and then close the extraction space. Well, even we extract the second molars out, the root positions very close to each other to the first molars. I don't afraid to close such a big distance with aligners. because the root doesn't have to travel so long. So we extracted the second molars out and bring the third molars in. In this particular patient, I didn't use accelerant, we just use regular aligners every 7 days. So these patients, we see the 3 months later we have diastema, even the patient is 40 years old. And then we extracted the second molars out and then close the space and extractions of lower incisors and finish with 3 incisors. So we gradually close the extraction space and patient use some of the class 2 elastic and completed the case. So you can see very protrusions and very crowded situations use minuscule assisted expansion appliance with lower incisor extractions can finish the case. So total treatment was 18 months. And then I removed the minuscules out. And this is a transverse first approach before and after treatment. Because I decided to extract the second molars out, I didn't use motion appliance for this particular case. Lower third molar positions are pretty much parallel each other with alignment. We didn't use any wires for this case. So the total treatment for alignment, I spent 2 months with minuscule assisted RPE. The profile is improving before and after treatment. And this is a patient's smile. And this is the last case for my presentations. This is a skeletal class 3. And you can look full cut. To me, one option is to extract lower premolar extractions to compensate or the camouflage treatment, or maybe surgery to finish the case since the alignment is relatively good. But this particular case, I decided to go minuscule assisted RPE with the motion appliance on the lower. So this is to me the full cusp class 3, and which is relatively difficult to establish class 1. 1 month later, I gained some of class 3 corrections, and I continue to expand more. 2 months later, I see some space between incisors, and then we are pretty good shape for canine relationship. The canines are pretty much class 1. 3 months later, now compare with before treatment. This is, to me, significant change. I am now comfortable enough to switch everything to aligners. So now I cut out the tubes, and this is before treatment photos, and 3 months motion appliance to correct it to class 1. And after the class 1 canine relationship, and we are pretty good shape, and the aligner can control the rest of the positions. So now we are ready for aligners to finish the incisor repositionings. And minuscule assisted RPE usually brings some of the maxilla forward, which really contributes class 3 corrections, and which tends to extrude, or maybe the vertically tends to open, but we have maintain the molar vertical positions, so So which is good combinations with minuscule assisted expansion appliance with aligners. So advantage number 3, sometimes the transverse corrections with motion can really enhance the entire corrections. So my presentations in this afternoon, I show some of elimination of the facial mask, and maybe the aligner with a class 3 elastic will eliminate the big operations. Sometimes correction coordination with the surgical correction with motion appliance is much less invasive and very easy to apply. So this is all about my afternoon sessions. Thank you very much for your attention. Thank you. Thank you.
All right, great. Thank you, Dr. Kaku. Excellent presentation. Thank you. So at this time, feel free to speak with any one of our HSO representatives regarding the new clear aligner system that Henry Schein just released to the world today. An incredible new component in addition to the portfolio for the organization. Again, the clear aligner system, anyone here in the College Church can go ahead and answer those questions for you. And that will conclude our in-booth lecture series for today. We will start up once again tomorrow morning at 10:30 a.m. So thank you.